is present. I think so. Very well.
Good
We see the
afternoon,
picture.
colleagues. Yes.
We also can hear you. And so I can introduce our next speaker, Dr. Inessa Telezhnikova from Russia.
Okay. Good afternoon, dear colleagues. Tell me, please, can you see my demonstration? Okay. Yes.
Yes, we can see your presentation and we can hear you loud and clear.
Okay, I will start. Let me introduce myself. My name is Inessa. Thanks for a wonderful opportunity to give our presentation here. The topic of our presentation is the role of digital radiography in histopathologic evaluation and surgical breast cancer specimen after neoadjuvant chemotherapy. Thereafter, declare no conflict of interest. A little about us. We are from Russia. We work in Moscow Clinical Center. We process more than 2,000 of breast cancer per year. Now some of the patients are participants in the randomized clinical trial study. The aim of other study was to optimize the pathological assessment of residual disease in breast cancer after neoadjuvant chemotherapy in Russia. Neoadjuvant chemotherapy is being used more frequently worldwide today. Recent years have seen a shift toward greater use of preoperative versus postoperative chemotherapy for breast cancer. Tumor response is associated with disease-free and overall survival. NEC provides us a unique opportunity to assess response to treatment after months rather than years of follow-up. However, significant variability exists in pathologic assessment methods of response to NEC, and thus its interpretation for subsequent clinical decision. Pathology complete response is a strong predictor of outcome after neoadjuvant chemotherapy. There is general agreement that PCR should be defined as complete absence of tumor cell in the breast and in the lymph node, total PCR or TPCR. On this graph, you can see comparison of disease-free survival in 7,017 patients achieving PCR according to breast cancer intrinsic subtype. PCR is a suitable surrogate endpoint for patients with luminal B and HER2 negative and HER2 positive non-luminal and triple negative disease, but not for those with luminal B, HER2 positive or luminal A tumor. The analysis highlighted discrepancies between RCB and YAGCC stratification. 41% of patients had discrepant RCB and YAGCC scores. We report both RCB and YAGCC for patients in order to identify those at highest risk of relapse. I would like focus on the role of the pathologist. The pathologist's role in the treatment and probable outcome of the patients is critical and too often overlooked. It is not uncommon so that to be no correlation between clinical and pathological methods to determine response to NEC. Clinical method had some both false negative and false positive response. So histopathologic evaluation is gold standard. The pathologist has different problems related to sampling for histologic evaluation. This may be lack clinical data or clips, for example. Also, triple negative breast cancer with little or no tumor stroma may regress without leaving a tumor bed. Detection of clinically occult lesions has problems such as, for example, not palpable, not visible. Can you see in this picture? We don't see any fibrous tissue. Analysis was 30 patients who underwent radical surgical treatment after neck. Those patients had a non-palpable breast cancer, and for found lesions at gross dissection, we used imaging the Faxitron system. Data on the patient's tumor and surgical factors were collected. In some European and American guidelines, we found some information about the possibility of using digital radiography. It should be noted that Russian recommendations do not contain any information about it. Thus, we used a new approach in other countries. Technical consideration, big camera, adequate for mastectomy specimens, can be run in the laboratory without concern about any radiation. Small dimensions allowing it to be installed in almost any pathomorphological lab. The results are available within from 10 to 30 seconds. 10x geometric magnification with precise measurement at any level, which allows you to see pathological microfocuses invisible to the human eye. The specimen was sent within and others to a pathology lab. We were informed of the site of the primary tumor in the breast, particularly within mastectomy specimen, as well as the presence of any accompanying markers, for example, metallic clips. We used multiply in colors. Radiograph was after the specimen's margin. Margins have been oriented and inked, and the specimen had been serially sliced. Same coloring is applied to the adjacent edges of the tissue sections. Specimen radiography reports were compared to the histopathologic evaluation, microscopic and macroscopic parameters. It has been found out in the 4 grades. Its RCB0 was 57%, and RCB1 was 10%, and RCB3 was 30%, and RCB3 was 3%. Magic resection in all patients was negative. The tumor bed was detected in 29 cases using digital X-ray. Immunohistochemistry is not mandatory, but can be very helpful to identify, isolate tumor cell. The same in lymph node and tumor bed. The tumor bed was not reliable detected in the only one case. However, it was possible to identify photos of lymphovascular invasion in area microcalcification. So we got a YPT 0 by AGCC post-neoadjuvant staging, and it is not classified as PCR. CLIPS and microcalcification were detected in all patients. The size of the tumor bed on the digital image was less compared to the gross examination. In this manner, removal of any CLIPS and microcalcification is confirmed in the intact specimen, and location can be determined within the specimen, and no mechanical dislocation of the CLIPS occurs. It is important to note that the identification of microcalcification acts as a significant parameter, since microcalcification are an indicator of a tumor bed. So in conclusions, in the case of non-palpable lesions in the breast, it is impossible to reliably measure the degree of tumor regression after neoadjuvant chemotherapy without using the path-vision Foxytron system. Due to the histological structure of the breast and fibrous tissue, it is easy to miss essential areas during a gross examination. Also, the use of this system reduced the incidence of sample redissection and the total study time. Finally, path-vision has become much accepted in other departments. Thank you for your attention and for coming to presentation. As you can see in the picture, the winter in Moscow is getting warmer, and we have little snow. And take care. Thank you very much.